Another physiological consideration for pediatric patients is their fluid balance, for they can become dehydrated rapidly. The healthcare team will measure the patient's renal output carefully. Gastrointestinal surgeries increase the patient's risk of dehydration and electrolyte shifts significantly. Additionally, hemostasis is critical because infants don't have a large blood reserve. Blood loss must be accurately measured. The surgical technologist must report the cumulative amount of irrigation fluid used during surgery, and used sponges must be maintained carefully and weighed to determine blood loss. We must always be at the ready to provide necessary supplies during critical moments of potential hemorrhage. The airway is one of the most important anatomical differences between adult and pediatric respiratory systems. The pediatric airway features a larger tongue in relation to the size of their mouth. They are obligate nose breathers, which means they haven't figured out they can breathe through their mouths yet. And they have a much shorter trachea. Their trachea is smaller in diameter and more difficult to secure. That smaller airway is also more delicate because it's not as well supported by muscles like in adults, due to the fact that cartilage develops before muscle does. They have a weaker thoracic wall and a lower residual lung capacity, meaning they could easily have their lungs overinflated, leading to injury. Failure to manage a pediatric patient's airway is among the leading causes of death in a medical or traumatic emergency. What this all means to you, the ST, is you may be called upon to assist the anesthesia provider to access the airway more than usual, which is less likely with your adult patients. And when you're not called upon to actively assist with the patient, it's best not to interfere at all, because increased noise in contact with unknown people tends to increase the patient's anxiety, leading to negative reactions. Speaking of anesthesia, many of the procedures performed on pediatric patients really could be done with local or regional anesthetic. However, most are performed under general so that airway management can be obtained. Furthermore, children often struggle to cooperate during surgery due to their fears, the fact that they don't know what's going on. They're separated from their caregivers, and they're likely experiencing pain or discomfort. Some of the considerations regarding pediatric anesthesia include involving the family as well as the patient in the discussion. Pediatric patients will still look to their caregivers for information first, and not their doctor. Therefore, it's wise to inform the caregivers of what will happen and what to expect. Also, the drug use dosages for children are much more sensitive. I'm sure you all recall the video Jennifer Ferguson shared with you regarding Emily Jerry and an outcome of her medication error. The reality is that medication errors are incredibly easy to make in pediatrics, so we must be diligent in their preparation and labeling. IV fluids require micro drip tubing because they're more accurate at delivering fluids than their macro drip counterparts. It's important that the patient's system not be overloaded with fluid. Pediatric patients are often induced with inhalation drugs as opposed to IV drugs. The reason for this is inhaled anesthetics do not require IV access, and they have a rapid onset. Alternatively, because there's always a risk associated with surgery, inhaled anesthetics can promote airway irritation because they have such a pungent smell. Everyone must be on their toes during induction to ensure adequate response if needed during an airway emergency. Finally, and this one takes us back to the preoperative phase, is we know patients need to be NPO before surgery, and not allowing a child to eat or drink when they're hungry or thirsty doesn't typically go over very well, although it's still necessary. That's the most common reason why you'll typically see the youngest patients at the beginning of the day and progress in age from there. Preparation for anesthesia includes proper assessment of the patient. Psychological preparation may vary based on how the patient presents themselves in the perioperative environment. It's customary for healthcare providers to familiarize the patient with the room and its contents, and even allow favorite objects into the room to accompany the child until they are successfully under anesthesia. The method of induction will depend on several factors. Earlier in this video, I told you that most often pediatric patients are induced via inhaled anesthetic drugs. Sometimes, though, this is not the best option for the patient. The age of the child, whether or not the patient has IV access yet, the presence of a parent, the skill of the anesthesia provider, and the patient's ASA number are all key contributors to the decision-making process. It is not uncommon for pediatric patients to be given an anxiety-reducing medication before surgery. Parental presence during induction is now an accepted practice in many health facilities. As this slide indicates, there are still multiple ways to achieve induction, including mask inhalation, intramuscular injection, rectal suppository, oral medications, and IV injection. If and when a patient arrives in the OR asleep, which is fairly rare, they typically receive blow-by anesthesia of inhalant. Psychological care, which again is a major factor of consideration in pediatric surgery, involves the child, their parents, and the perioperative staff. It is best practice to establish a rapport with the patient so they are not excessively fearful of you, although that is not always possible depending on the developmental stage of the patient, which we'll get to on the next slide. Depending on the procedure or procedures planned, it may be advantageous for the family and patient to visit a child life specialist. A child life specialist is trained in providing age-appropriate counseling to the family and patient. A preoperative visit or counseling session helps reduce anxiety and allows both the patient and family to ask questions before surgery. Preoperative education is a major goal of the perioperative planning of the patient and family. All surgical staff need to understand the basic developmental stages and their significance in the perioperative environment. You will want to study the common behaviors of each age group provided in your textbook. In addition to all we've already discussed, we must not forget that the environment must remain safe for the patient in all the ways that we make it safe for every patient. Every patient is at risk for a wrong site surgery, retained foreign objects, medication errors, and for a perioperative team to be stressed or fatigued. We must not allow these environmental risks to come to fruition, and so we will collaborate with the OR team members and address specific developmental stages among all the practices we do for every patient to keep them safe while they're in our care. Safe handling of drugs includes understanding that the size of the patient puts them at a greater risk for accidental overdose. Medications will be prescribed by weight in kilograms. Practice converting back and forth between pounds and kilograms, remembering that 1 kilogram weighs 2.2 pounds. Give yourself some examples, such as a 5 kilogram patient weighs how many pounds? A newborn that weighs 7 pounds and needs a dose of preoperative antibiotic that's 100 milligrams per kilogram would receive what dosage? All non-anesthesia medications must be verified with the surgeon, the circulator, and the surgical technologist. Cumulative amounts of drugs that are given through the procedure must be recorded and tracked in real time to prevent overdose. They are not reported all at the end like in adults. When transporting pediatric patients, it's important to know the different methods available. Obviously, this pertains to those in younger developmental stages. The isolette on this slide is environmentally controlled and equipped with monitoring devices. Transporting an inpatient toddler can present challenges. It is critical to ensure the child does not climb over the crib or stretcher rails and does not extend their limbs through the rails. When positioning the patient, we apply the same principles as with adults and use appropriately sized padding. Care must be taken when moving the patient's body. Keep in mind that although we use the same tactics regarding range of motion as we do with adults, children are often hyper-flexible. It's important to avoid using adhesive tape because it could lead to skin tears and injury in pediatric patients. The final slide for your video pertains to electrosurgery and the pediatric patient. We will apply the same principles as with adults with the same equipment, devices, and supplies, except pediatric return electrodes are sized according to their weight. A patient return electrode must never be cut or trimmed, no matter the size of the patient. That's all for now. I'll see you soon.